All right. Well, good morning, everybody. It is a couple minutes after 10 o'clock on Thursday, June 10th. For folks who don't know me, my name is Lee Storo. I'm Executive Director of NC AIDS Action Network, use he, him pronouns, and are really thankful that y'all took time out of your schedule to join us today. We have hosted at the height of COVID regular Thursday morning 10 a.m. webinars as a way to keep our community together and share information. Now that we're a little bit, headed out of this time and able to do more stuff in person or doing less virtual programming, but particularly in this month as we head into this transition with Medicaid Managed Care, really want to make sure we focus in on some important information this month. I'll give one quick plug for another virtual program we are hosting this afternoon. At 6 p.m. Eastern Standard Time tonight, we are hosting another edition of Club NCAN, our Clubhouse audio-only conversation that Matt Martin, Dante Prayer, and I have been hosting every other Thursday. This Thursday, we are going to be chatting with Cody Kinsley, who is the Chief Deputy Secretary for Health at DHHS. He leads their statewide public policy work and also is the COVID-19 lead for DHHS. So our conversation this afternoon is largely going to focus on the state's response to COVID and also some important LGBTQ health topics to mark Pride Month. If you have not heard of Clubhouse, feel free and are interested in listening into that, feel free to be in touch with myself. You can direct message me below or shoot me an email at lee@ncan.org. Clubhouse is a relatively new audio-only app that we've been using to try to just experiment and do some different kind of programming. You do have to have the app and have an invitation from someone, and we're happy to share an invitation with you. That's relatively easy to get. I think some of us enjoy it because it just takes away the video component completely, and you can just sort of chill back and wind down your day and listen to some fun conversation about health policy and LGBTQ pride and health issues. So would love for folks to join us. With that, I am going to pass things off to our two presenters. This topic around Medicaid managed care is a really, really important one for the state of North Carolina. Many of you have probably heard us talking about the transition to managed care multiple times over the years. It has been a process that started and stopped in North Carolina, but we are in the middle of implementation phase and the transition goes live July 1st. For a number of reasons, this is really important to our community. Y'all have heard me say before that Medicaid is the #1 insurance provider for people living with HIV, making it an especially critical program. And this is one of the largest changes to the way the Medicaid program has operated in state's history. So it's pretty important. I'm going to pass things off to our two presenters. We have two real experts on this topic. Elizabeth Edwards is senior attorney at the National Health Law Program and is based here in North Carolina in their North Carolina office, has a long history of doing policy work in North Carolina, including spending 5 years at Disability Rights North Carolina. And presenting with her will be Becca Friedman, attorney and Equal Justice Works Fellow at Charlotte Center for Legal Advocacy, one of our longtime partners and a real champion for all people, including people living with HIV in North Carolina. Becca and Elizabeth, thank y'all for your expertise, and I'm going to pass the presenting off to y'all. Thanks so much.
Thanks so much, Lee, and thank you everyone for having us. As Lee said, I'm Becca Friedman. I'm an attorney and Equal Justice Works Fellow, sponsored by Kilpatrick, Townsend, Stockton at Charlotte Center for Legal Advocacy, and I'm joined with Elizabeth Edwards, and we're really excited to be with you as we're just 3 weeks away from managed care plans going live on July 1st. So today we're going to go over sort of what the transformation means at a high level, the transition to managed care, and how it differs from the Medicaid system now. We'll go over the enrollment process, both procedurally, what beneficiaries have to do to join one of these new plans, and also who has to enroll, who cannot enroll, and various other categories. And then we'll provide a lot of resources available to Medicaid beneficiaries and their advocates as everyone tries to navigate these changes. And so just as a little background, North Carolina's Medicaid system as it stands now is a fee-for-service system covering over 2 million people in North Carolina. The fee-for-service system basically works where the state pays providers directly for their services they provide. And the Medicaid transformation to managed care will shift away from that fee-for-service system to a capitative system of comprehensive managed care. So currently there is some managed care in North Carolina for the local management entities or managed care organizations or LME-MCOs for behavioral health and intellectual and developmental disabilities. Um, but and there is some community care of North Carolina helps coordinate care for physical health services, but this will be a much more comprehensive managed care program. And most current Medicaid beneficiaries will be required to enroll in one of these capitated managed care plans. They're known as prepaid health plans or PHPs. You'll also hear them referred to as standard plans. And there are 5 primary plans, as well as an Eastern Band of Cherokee Indians tribal option. So this map just shows how regions are divided for the managed care transformation. This map used to be more important the first time around that transformation was supposed to go live back in 2019 because it was going to be a phased rollout. Now they're doing a statewide rollout where the whole state is going live at once, but the regions are still relevant for some of the health plans or various other elements of the transition to managed care. So under the managed care system, as I said, there are 5 primary prepaid health plans or standard plans. 4 are available statewide. 1 is only in certain regions. Each plan will have a provider network. So generally, Medicaid beneficiaries will have to get their services through providers in their plan's network. The goal of the managed care transformation is to focus on better health outcomes and care management and really focus on whole person health, not just medical, but really combining the medical and the behavioral and coordinating care for beneficiaries. As I said, there will be standard plans for most Medicaid participants, and then there will be another type of plans called tailored plans going live 1 year later, so in July of 2022, and those will be for individuals with severe mental illness or developmental disabilities. And we'll go into more detail later, but eligibility for that will basically be based on certain diagnoses or services that you use. So for the local management entities or managed care organizations, also known as LME-MCOs, so until July of 2022, they will continue as they are managing care for mental health, developmental disabilities, and substance abuse disorders, but only for those with severe conditions. And we'll go a little bit more into what qualifies you for one of the LME-MCO services or a tailored plan. And until July of 2022, physical health care will continue in the current fee-for-service structure, also known as North Carolina Medicaid Direct. So a year after the standard plans go live, the tailored plans will go live, and they will be the current LME MCOs, so that includes Cardinal, VIA, Partners, Alliance, et cetera, they will transition into the tailored plans. They will manage both mental health, developmental disability, substance abuse services, as well as physical health care. And again, only for people who qualify for these or meet certain eligibility criteria for the tailored plans. There will only be one tailored plan per region. So unlike the standard plans where beneficiaries have a choice of plans, beneficiaries who are enrolled in a tailored plan will have to enroll in the tailored plan in their region. And as I said, only current LME MCOs can apply to be tailored plans for now at least, and it's a 5-year initial contract. So I won't read all of this, but we can share the slides later. This just sort of goes through the behavioral health services that are available in the standard plans versus the tailored plans. So everything listed on the left column under standard plans is also available, will also be available through the tailored plans or currently through the LME MCOs until next year. Once the tailored plans go live, the additional behavioral health services on the right will be covered by those tailored plans. So that includes waiver services such as innovation waivers, state-funded behavioral health and IDD services, assertive community treatment, psychiatric residential treatment facilities, and much more. So while there are a lot of changes, a lot of things are still staying the same under the Medicaid transformation. So eligibility rules and application processes for Medicaid and North Carolina Health Choice or CHIP will not change. So new applicants will still go through their local Department of Social Services or DSS offices to apply for Medicaid. That won't change initially. Cost sharing won't change, so beneficiaries should not have to pay any more than they are now for services. So the amount of copays on Medicaid and CHIP will still be the same. Covered services should also remain the same. So clinical coverage policies, at least initially, will stay the same. Some of the plans have added certain services that are approved by the state, and some are called value added services, for example, but the services that are required to be covered under Medicaid now will continue to be covered under all of the health plans. How services are authorized and given to the populations that do not have to enroll. So the exempt populations include those who are eligible for tailored plans. They will still have their services authorized and delivered as they are now through the LME-NCOs. And then the waiver wait list. So for example, the innovations waiver and the TBI or traumatic brain injury waiver, those wait lists and the processes will stay the same. So most of the Medicaid services that Medicaid is required to cover and will continue to cover will be covered by these standard plans or prepaid health plans. There are some carved out services that will continue to be covered through fee-for-service Medicaid, including dental, eyeglasses, local education agency services, and then a few others. And as I said before, some of the plans are offering certain additional services known as value added or in lieu of services. These are approved by the Department of Health and Human Services. Additionally, non-emergency medical transportation will be the responsibility of the prepaid health plans now, and this is really critical because now, as it stands now, Medicaid beneficiaries who need transportation to appointments or other medical services can request non-emergency medical transportation through their local DSS office. Now the prepaid health plans will begin to cover those, although individuals who will be enrolled in the tailored plan or who remain in fee-for-service Medicaid, as well as individuals enrolled in the Eastern Band of Cherokee Indian tribal option, will continue to receive transportation through the local DSS. But for all beneficiaries enrolling in the standard plans, they will go through their plan, and there's a designated phone number for NEMT for this transportation that they can call, and they can begin calling. Well, they could have started calling as of June 1st for services July 1st forward. So for Medicaid beneficiaries who know they have appointments start on July 1st or after, they should call their plans now to set up that transportation. Healthy Opportunities pilots is another innovative aspect of the Medicaid transformation, and these are not going into effect yet, but they will be a big component of it. These are supposed to provide evidence-based non-medical interventions for high needs individuals on receiving Medicaid. So for individuals who meet certain eligibility criteria, indicating that they have certain needs that are non-medical drivers of health related to, for example, housing, food, transportation, and interpersonal safety, will be eligible for services through these Healthy Opportunities pilots aimed to focus on social determinants of health and improve health outcomes while reducing healthcare costs by realizing that there are so many non-medical drivers of health that Medicaid beneficiaries are impacted by. So these will be managed. So the PHPs or standard plans will manage the pilot budget, and they will work with lead pilot entities, which I believe have been changed. So they're now, the lead pilot entities are now called Healthy Opportunities Network Leads, but they were recently announced just in the last couple of weeks who these pilot entities are, and there were three. They'll cover 3 regions of the state. So they are Access East, Community Care of the Lower Cape Fear, and Dogwood Health Trust. And I believe that 2 of them are on the eastern side of the state, sort of one in Northeast Carolina, one in sort of the Southeast Carolina and North Carolina, and then one is in the western part of the state, like in the Asheville area. And again, these will focus on social determinants of health services. There are also a lot of beneficiary protections built into the Medicaid transformation, and these are things that we as advocates and attorneys and representatives are really focused on, and making sure that we are monitoring and noticing issues with them, and making sure that we'll enforce that they actually are put into place as required. So this isn't everything, obviously, but the Department of Health and Human Services must approve all marketing materials, and there are limits on plans engaging in direct solicitation of individuals to join their plans. Health plans must provide language assistance services, including interpretation and translation, and this includes written and oral materials translated or taglines in the top 15 most common non-English languages in the state. There are many detailed grievance, appeal, and state fair hearing procedures, including timeliness. So appeals are available when an individual was denied a service or a service they were receiving is reduced in the amount of hours, for example, or terminated. They will be able to appeal that decision. And then grievances are basically for any complaint that doesn't rise to the level of an appeal. And after an appeal, there's a state fair hearing process, which we'll go into a bit more later. Health plans must also have various services available and resources for their members. So this includes including for long-term services and supports, and transfers to different health plans or different providers when that becomes necessary. And health plans also have to have certain member service lines, such as, well, a member service line, a behavioral health crisis line, and a nurse line, to make sure that beneficiaries can contact the appropriate resource at their plan to get the care that they need. And with that, I will hand it over to Elizabeth.
Great, thanks, Becca. So Becca sort of gave you an overview that this is somewhat complicated, and some people have to enroll in managed care and some people don't. And it really very much depends on diagnoses and a bunch of other factors. And so we're going to kind of try to quickly explain who is in, who is out, and who has to do what right now. So as Becca explained, there are these standard plans, and most people in Medicaid have to enroll in them. And they had until May 21st to select a health plan or PHP and their primary care provider. Those who did not select a health plan have been auto-assigned to one based on criteria selected by the state, which includes things like their primary care physician, or if some other family member, their choice of plan or primary care physician. So members who did not also select a primary care physician were also assigned to a PHP and to their provider. So the state ran this assignment process in March 2021 and reassigned about 150,000 people who had not selected a plan and not visited a current PCP in the last 2 years. So one thing to note, in that it changed more recently, is that tailored plan eligible beneficiaries will remain in North Carolina Medicaid Direct. So all their services will stay the same through July 1st. So this changed recently. Some, and I'll go into this a little bit later, but some tailored plan service recipients or LME MCO service recipients had selected a plan, which they could do, but the fear is that people may not have realized that they may lose LME MCO services by selecting the plan. And so the state is going to keep those individuals in Medicaid Direct until more information can be provided to them about services differences. So the plans will mail out welcome packets and new ID cards. Most people should have those. They're supposed to be out by June 12th. And one important piece of information to know is that even though a person may have been auto-assigned to a plan, they still have 90 days after July 1st to change their plan for any reason. And that could be whether or not they chose the plan or were auto-assigned. They can just change for any reason for up to 90 days. So after that 90-day period, members can only change their plan for good cause. And there's a long list of good cause reasons, but it's not, it is a limited list. And you can appeal a denial of good cause if it happens, but you still may lose if it doesn't fit into the criteria. So here's a chart that tries to simplify who is in managed care and who is out, and who sort of may choose managed care or not. So as Becca said, almost all Medicaid beneficiaries in North Carolina, in terms of numbers wise, will be enrolled in managed care through these standard plans. So that's most families and children, children receiving health choice, pregnant women, and people who are blind or have disabilities are not receiving Medicare. importantly, Medicare is out. There is a kind of group of people in the middle who could choose to enroll in managed care or not. And that includes the federally recognized tribal members and other people eligible for services through Indian Health Services. And as Becca mentioned, people with significant behavioral needs, intellectual and developmental disabilities, traumatic brain injury, and substance use disorders. So these people could choose a plan, but don't have to. And as I noted before, because of potential confusion, even those who enrolled in a standard plan are going to stay in Medicaid Direct, at least for now, until more information can be given to them about what are the differences in services. As Becca mentioned, if you currently receive LME MCO services and move to a standard plan, you won't be able to access some of those important behavioral health services if you move to a standard plan. So importantly, who is excluded? Excluded is largely a lot of sort of people with disabilities and older adults. So you have people who are on any of the HCBS waiver services are excluded, as well as people who have received Medicare, even if they have both Medicaid and Medicare, and health insurance premium program, and a few others. So where are we now? As I mentioned, we are past the point where people were choosing plans. Sort of initially, auto enrollment has happened. Letters of enrollment packets have been mailed to beneficiaries, and we have passed the point of auto enrollment. And now, so 97% of those eligible for managed care are enrolled in a health plan that at least includes their known primary care physician in their network. But as you know, important to note that a lot of people, their specialist is actually more important to them than their primary care physician. So it may be that even if a person has their primary care physician in their network, their specialists that are really important to them might be out of network. So people really need to check to make sure that the specialists they really rely upon are in their network and change if necessary. As I mentioned, people have 90 days from July 1st to change. So the end of the choice period for plans is September 30th. So I also wanted to flag that people have been receiving a bunch of different letters, either from DHHS or from providers or from the enrollment broker, whoever. There's been a lot of information going out to beneficiaries. Helpfully, the department has posted all of the notices they've been sending on the county playbook website, and the link to that is on this slide. So there's been a bit of confusion because some people who are exempt might have received mandatory letters. Some people who, the state tried to match it up with data, but it wasn't perfect. So people may have gotten a little bit of confusing information. And those who were exempt did receive letters talking about enrolling in managed care, and that could have been very confusing. It's especially confusing for new people to Medicaid because there wasn't necessarily historical data for those people. And then the other kind of confusing part is in trying to be helpful, providers are often sending letters saying, here are the networks we're participating in, and these are the plans you should enroll in if you want to keep us as a provider, which is generally helpful. But for people who are in the exempt population or excluded populations who don't have to enroll in managed care at all, that can be very confusing. That's especially true for people who receive LME MCO services and might be losing those services if they enroll in a standard plan. So there's two different ways a person can stay in Medicaid Direct or Medicaid fee-for-service, kind of keep things the way they are now. You can either stay in Medicaid Direct through diagnosis, which includes the list I have there, or you can stay in Medicaid Direct because of the type of services you use. So as Becca described, a lot of the LME MCO services are how somebody will stay in Medicaid Direct, at least for now. And there's a long list of diagnoses in the link that's at the bottom of this slide. So how do you stay in Medicaid Direct? It's basically a form, and you can fill it out. Providers can help people fill it out. The provider can also request disenrollment or transfer on a different form, which we have linked here. And DHS there is required to make a decision, mailed to the beneficiary, and that decision about whether or not you can disenroll from managed care can be appealed to a fair hearing at the Office of Administrative Hearings within 30 days. All of the forms that for Medicaid Direct and keeping your Medicaid as it is now can be found on the links on this slide. So I'm going to turn it back over to Becca to talk about who can help. North Carolina has a lot of mechanisms in their managed care system for assistance for beneficiaries.
Thanks, Elizabeth. So now I'll just go into resources available to Medicaid beneficiaries as they navigate these changes. So many of you may have heard of the enrollment broker at this point. The enrollment broker played a huge role, especially during the enrollment period, but will continue to be present throughout the through managed care. And the enrollment broker's role is to help beneficiaries understand what managed care means, whether they have to enroll, what these categories we've been talking about with mandatory, exempt, excluded actually means, and what it means for individuals who are trying to navigate whether they had to choose a plan and whether they have to move into one of these prepaid health plans on July 1st. They also assist with the enrollment process. So beneficiaries could, one option for enrolling in a plan was to just call the enrollment broker and have the enrollment broker directly enroll them in one of these prepaid health plans. They also have to communicate with individuals in their preferred methods. So they have an email, a phone, texting, and mobile. They have a live chat on their website, and there's also a mobile app that beneficiaries can use. They've also been conducting a lot of outreach and proactive engagement to facilitate enrollment throughout the open enrollment period. And they're required to provide unbiased and culturally competent choice counseling to enable beneficiaries to select the plan that's best for them and will best meet their healthcare needs. They also must provide accurate information to help consumers compare plans and compare the provider networks to allow intelligent choices of health plans. So as Elizabeth said, while 97% of Medicaid beneficiaries are enrolled in a plan with their PCP, for many Medicaid beneficiaries, they may care more that they're able to continue seeing some of their specialists who aren't necessarily in their network. So the enrollment broker is required to help beneficiaries learn if the providers that they want to continue seeing are in their provider networks or in their health plan's provider network, and if not, find what plan will be best for them. They also, at this point, now that people are enrolled in these plans, they have to assist in disenrolling from plans and also changing between plans if requested or needed. And the website for the enrollment broker is at the bottom of this slide. The North Carolina Medicaid Managed Care Ombudsman is also a resource for beneficiaries. This is a joint effort and collaboration between Legal Aid of North Carolina, Charlotte Center for Legal Advocacy, and PISCA Legal Services, but it's an independent entity that will provide services to Medicaid beneficiaries. The contact information is there, and community partners can also request outreach events from the Ombudsman to learn more about the services provided. And the next slide, we'll go into more of what the services do provide. So the Ombudsman will provide free confidential support and education about Medicaid beneficiaries' rights and responsibilities under North Carolina Medicaid. The Ombudsman will also connect people to resources for various needs. It's supposed to be a no wrong door approach, so they can connect people to resources like legal aid, social services, housing resources, food assistance, and more. And their 4 core responsibilities are to educate Medicaid beneficiaries, advocates, family members, other community stakeholders, to advocate for beneficiaries' rights, to refer Medicaid beneficiaries to services to meet their health or non-medical needs, and also to communicate with North Carolina Department of Health and Human Services and other partners to monitor issues that they're seeing and advocate for fixes in the system to really help the program meet its goals. The Ombudsman sort of went over this already, but basically they just educate and inform and assist Medicaid beneficiaries with questions about the transformation and provide general information and referrals for a wide range of issues. And their contact information is available there. And then I will hand it back to Elizabeth.
Thanks, Becca. And I also wanted to flag for people, we're happy to answer questions, especially we'll have some time reserved at the end. So if you have questions, I see a few in the chat already, but please feel free to ask them and we'll try to address them. So I wanted to go over some other beneficiary protections. Importantly, some of how an individual navigates their way through Medicaid changes under managed care, especially when you want to appeal a decision that you disagree with for denial of services. So some basic beneficiary rights under managed care. As Becca mentioned already, you're able to get free advice over the phone from the enrollment broker about plans and whether or not exempt and which plan might fit them the best in terms of the providers available and some other services available. As we said before, you can switch plans for any reason within 90 days of coverage beginning or for a good cause at any time of the year. The people will also be able to change plans when they're redetermined for Medicaid. So this is not a forever thing, but it's really only once a year unless for good cause outside of this 90-day enrollment period. An individual can always request to disenroll from a plan or from managed care from the enrollment broker and appeal if that request is denied. People can also get out of network care if medically necessary services are not available promptly in the health plan's network. That is a process. And there's supposed to be no interruption of care when transitioning between plans or out of managed care. And as I said, you have the right to appeal if the health plan denies, reduces, or stops coverage for needed health care. There are some important care management requirements in North Carolina's Medicaid Managed Care. More Medicaid enrollees are supposed to have access to care management to address medical and the non-medical drivers of healthcare. As Becca mentioned, people enrolled in standard plans will have access eventually to the Healthy Opportunities pilot programs. And local care management is supposed to be provided by Tier 3 advanced medical homes and their local health departments. So there's supposed to be more kind of active care management. And the standard plans or PHPs will have to identify high needs members needing care management and provide that care management to help them access the non-medical drivers of health, including those that we mentioned earlier for the healthy opportunities, including housing, food, transportation, interpersonal safety. And this plans must provide transitional care management for those moving from one clinical setting to another. So they have to employ, the plans have to employ housing specialists, they have to assist with staff applications and refer to medical legal partnerships. And there is a preference in the setup of managed care in North Carolina to prefer local care management, sort of inside of care, home, or community that is face-to-face rather than sort of some sort of telephonic or remote care management. So this is really important. There are transition of care protections in the managed care design. So both the plan and the LMEs must transfer information necessary to ensure continuity of care. There's some requirements about data sharing and other information. And the standard plans must honor existing and active fee-for-service prior authorizations for 90 days after managed care goes live or until the end of the authorization period, if that end is sooner than the 90 days. And if a plan terminates or reduces an open authorization at 90 days, it has to issue appeal rights. So they also have to assist transitioning to an in-network provider at the end of the authorization period if necessary. So when you transition to managed care, you will be able to sort of keep your provider and keep your services for 90 days. And then at the end of that, if the plan is supposed to help you transition to an in-network provider at the end of the authorization period and provide ongoing authorization. But if they don't, you can always appeal the end of that initial authorization period. And they are also supposed to allow continuation of ongoing courses of treatment with their current provider in accordance with law. And this may extend beyond 90 days, and it's specific to certain types of treatment. And pregnant members may continue receiving services from behavioral health treatment providers without prior authorization until birth, end of pregnancy, or loss of eligibility. I would encourage you to look at the care management sort of transition of care policy that's linked at the bottom of this page if you have more questions that are specific to the transition of care protections, because they are important. This is a few of the other ones just to highlight in transition of care about paying for claims and authorizing services for people eligible for Medicaid eligible individuals and getting services from non-participating or out-of-network providers, equal to that of in-networks providers for the first 60 days after managed care launch. And the plan is supposed to bear financial responsibility of certain claims if a person's admitted to an inpatient facility. And there are some certain authorized unmanaged visits for outpatient behavioral health requirements as well. And for high needs individuals, the LME MCOs must give the standard plans a verbal briefing, and the plan is expected to provide follow-up. Now, this last one is kind of delayed right now because, as I said, anybody who's receiving LME MCO services is currently staying in Medicaid Direct until more information can be provided. But what's really important here is that as we transition to managed care July 1st, there are going to be some protections in place to at least try to get people's services to be maintained for a period of time, anywhere from 60 to 90 days, depending on what we're talking about. But then people will have to be preparing for changes in network providers and other changes under the managed care plan. So we talked a lot about like in-network versus out-network care. That's the major difference in managed care. Plans will be required to meet network adequacy standards. And these are sort of general standards about how many physicians or clinicians the plan has to have. But it doesn't always mean that people will be able to easily find care that they need or the care that they want, whether it's culturally competent care for their needs. The plan must cover out-of-network care, and it's only for a short list of services, which are listed here: emergency and urgent care, family planning services, care needed while traveling out of state, services not available in network in a timely manner, and during the transition of care period. And there's also that no primary care physician referral cannot be required for certain services, which include children's health, women's behavioral health, and behavioral health or substance use disorders assessment. Otherwise, plans may be requiring a referral from primary care physician to get certain services. So this is very tiny print. I apologize for that. And it's kind of hard to read, but I'll sort of work our way through it. This is the appeals process, and we really want to go over this because this is the big difference between what people have been experiencing in managed care and Medicaid, where if the state denies or one of their contractors denies a service, you can appeal that denial straight to the Office of Administrative Hearings, which is your fair hearing opportunity. Under managed care, if the plan denies the service, you first have to go through an internal appeals process within the plan. And if that appeal is denied, then you can go to the state fair hearing at Office of Administrative Hearings, like you've been previously. There are some requirements about people who are conducting the appeal that is internal to the plan, not having been involved in the original decision, but there is this internal process first. And there are mechanisms to get expedited internal appeals, but just wanted to flag that this is one of the major differences, other than a limited network of providers in Medicaid managed care. As I mentioned earlier, you can also appeal a denial of a request to disenroll from managed care directly to the Office of Administrative Hearing, and those appeals have to be filed within 30 days and follow some specific guidelines, which are not unusual for Medicaid hearings, but just wanted to flag that those are the places where you can find the rules about disenrollment appeals, which will also be something new. This is also, as I said, Medicaid managed care appeals are different. So they kind of follow under different requirements, but it really is still the same, that basically the notice must happen when a service is denied, discontinued, terminated, or reduced. And it has to include all the reasons why the decision was made, in the supporting criteria, and how to appeal the decision, including the appeal form and instructions, and how to, and the notice must also include how to request continuation of services pending appeal if to prevent services being stopped or reduced during the appeal. So here are a couple of issues to watch. The National Health Law Program has worked with managed care in states for a really long time. And these are sort of issues that we've also seen within North Carolina and the LME MCO system, and things that we think are going to be issues. So some people are complaining that there are not a lot of providers to choose from within the plan networks, and it may not be fully complete. It should be better now, but earlier on when people were choosing, it was not entirely complete. You still might not be able to find a plan that has all of your providers in one network, so that's going to be an ongoing issue. We have seen some enrollment issues, which is why the people who receive LME MCO services are not kind of put on hold, which was a good thing. There's also sort of issues with access to information. So like, why is a managed care plan denying services? why, what are they doing and how are they doing it? That can be more difficult under managed care, simply because it's another layer of administration. And there's also been problems with issues regarding access to services. So with more limited provider networks, you have fewer options and you may not be able to get services as quickly. And of course, we've often seen problems with notice and due process. But it's always important to remember that the state remains a single state Medicaid agency and is responsible for the managed care plans. But if you're having any of these issues, I want to encourage people to contact the ombudsman for the Medicaid Managed Care program, because that's, who's there to answer questions. Here's some other sort of options for issue resolution. But for individuals, the ombudsman is really going to be the most important access point for problems. And here are some additional NCDHHS helpful links for all the information that we've talked about today, especially sort of the county playbook and the transformation homepage. And then I think we wanted to make sure that we had time to answer questions for people. I see a few in the chat already. Let's see. So do any of the managed care plans mandate mail order for antiretrovirals? I looked at this a little bit a couple of months early on, and I didn't necessarily see it, but I cannot be sure about that. That was something that the enrollment broker should be able to help somebody figure out based on the plan criteria. Becca, do you know anything more about that? I don't know if there's mandatory mail order from any of these.
I don't. Yeah, I'm sorry. If someone's already enrolled in a plan, I would also recommend just calling the plan and asking if that's a covered service. But if I learn more, I can definitely pass it on to Lee.
Yeah.
Yeah, and Becca and Elizabeth, we can do a dive into that. I know that's obviously an important topic for our community, so I've noted that as a follow-up. And anything that we maybe don't have concrete answers to today, we'll be doing a follow-up email to everyone registered this afternoon, and we can do a subsequent email with additional information if we get clarifications from questions as well.
Okay, great.
Yeah, I was trying to think if any of the plans that the commercial plans I know have some of that, have that problem generally, but I don't know off the top of my head. I always just think of CVS Caremark when I think of that problem. That's because there's current litigation on that. Slides will be available. And let's see, could an infectious disease clinic be considered an advanced medical home? Becca, do you know the answer to that one?
I don't. I think that they're pretty open to providers enrolling as advanced medical homes. Now, the tier status is also another element. So as Elizabeth said, local care management will be provided by tier 3 providers. I'm not sure exactly on the criteria for infectious disease clinics to be eligible for AMH tier 3s or what tier, but that's another thing we can look into and follow up on.
I know initially the state was very much wanting advanced medical homes to sort of serve the needs of the community and provide the care management necessary, but we'll have to look into whether or not that's what are the criteria for advanced medical homes. The other question here is there an assumption that LMEs will collaborate with PHPs to deliver physical health services under tailored plans? I don't think that there's an assumption that that will happen. I think that a lot of people expect that the tailored plans will need to contract with someone who is more experienced in providing and coordinating physical health care, but that's not necessarily the way it has to happen. Some tailored plans may be developing capacity to try to do it on their own, but we just don't really know. It may depend on the tailored plan. Becca, do you know?
I don't, no assumptions that I'm aware of, but I would just clarify that the PHPs and tailored plans will be separate plans. It won't be like the PHPs are the ones providing the physical health for the tailored plans. The tailored plans will have their own provider networks to provide the physical health services. But like Elizabeth said, there's hopefully some collaboration to be able to build these networks. But that's definitely something once the tailored plans are announced, which in theory is supposed to be over the summer of this year, that the tailored plans will be announced, and then they'll begin to start building their provider networks.
Right. They're still going to be totally separate entities. It just maybe they contract with a commercial insurance provider to help them with the physical side. Any pertinent 340B information that can be shared for both carved-in and carved out covered entities? course, you would. Don't have anything off the top of my head that I can think of.
Yeah, I don't know anything specific. I would just say that all prescription drugs and other medications that have to be covered under Medicaid now do have to continue being covered under the Medicaid transformation under all of the prepaid health plans. So if something's covered now and you have access to it, it should be as you move forward or after July 1st.
So, and there's a follow-up question about the pharmacy benefits. I did, when I was checking before for pharmacy benefits, there is some information available on the enrollment broker's website that is like sort of the provider network checklist, or sort of not checklist, search function. I will say that it's somewhat hard to search for things, but you can, I think, limit it to sort of type of pharmacy, and sometimes you can identify those mail order pharmacies and maybe find the answer that some plans may be using the mail order pharmacies, and that may be an indicator that they force or require certain drugs to be provided through mail, but it's not clear. I think the best thing to do is probably to, if you, as Becca said, if you're already enrolled in a plan, call the plan and ask. And then also if you're not already enrolled in a plan, try to go through the enrollment broker, but it may end up being you still have to call the individual plans, because that might be a level of information they don't have readily available to them, and they may not give you the sort of the exact information you're looking for. Let's see. Are ID clinics, infectious disease clinics, and docs specifically included in network adequacy standards? I don't think that they are. I'm trying to remember. We were on the network adequacy subcommittee, and I don't readily remember that that was a specific category. But I will have to follow up because it could be. Are pharmacy networks, the other question is, are pharmacy networks accessible through the provider search? I was able to find pharmacy networks through the provider search. As I said, that provider search function is not perfect, but I was able to try to look for the answer to this sort of a related question about pharmacy benefits through the provider search.
Yeah, and I just put the provider search tool in the chat, and you can search by specialty, and there is a pharmacy option to sort providers. So we can't guarantee. One thing I would note about the provider search tool is it does not respond to typos. So make sure you know how to spell either the provider's name or the pharmacy or clinic's name when entering that in the search tool.
And it may have the provider's name as a typo. So try to be kind of short or truncate the provider name you're looking for to sort of help find it. And yeah, the provider search doesn't allow search for infectious disease doctors. I think that also is an indicator to me that that my sort of gut reaction to the question about network adequacy for infectious disease doctors is not, it was not that specific, and that's another indicator that it probably is not. This other question, the state HIV care program has been silent on this, but it seems like there may be a duplication between PHP care management and Ryan White case management. Have other communities that provide case management services developed an approach on this? I was actually talking to one of my coworkers the other day about sort of the duplication of care management that often happens in managed care, especially with Ryan White care management. And I don't know if that in North Carolina there has been developed a solution for this overlap, but he was sort of talking about how frequent it is that people with HIV/AIDS end up with multiple case managers or care managers, sort of trying to work on the same problem. And I don't know that there's been solutions developed regarding coordination of that care management. But it certainly happens a lot in managed care.
Yeah, I will say, at least for some of the care management programs through the local health departments, they do have to coordinate with the plans for the care management, so that it's not just completely redundant and duplicative. So I would imagine I think there are probably some built-in requirements, but I can look into that more as well.
I mean, I think that North Carolina tried to identify sort of care management intersections and trying to make that a little more, at least in terms of requiring information sharing, have some requirements around that, but a lot of it is more specific to people switching between plans or care or primary care physicians, and not necessarily about existing care management. But as Becca said, we'll look into it, and happy to sort of think through more of these issues and try to figure out what might be some solutions as well. But as I said, talking to my coworker who has looked a lot at like Ryan White care management and other programs in managed care, it seems like that is sort of an ongoing issue. And I don't know that it's going to be solved in North Carolina, especially if you consider the if a person is eligible for and is using the Healthy Opportunities pilots when they come online. A person may have like a Ryan White care manager. They might have something through the Healthy Opportunities pilots, and they may have their regular sort of care manager at their advanced medical home kind of structure as well. So there could be a lot of people involved. The idea is that those things should be coordinated, but we all always know it doesn't happen perfectly. And just wanted to flag that we have, so we set up, so the advocates, CCLA and HELP and Legal Aid and some others set up this email account just as like a place to answer questions. This was before the ombudsman came online. So certainly feel free to use this email account for questions, but the ombudsman is really the primary place to go to for questions, and they're all set up ready to help. This email account is sort of ours for gathering questions, and we'll refer people out as necessary, but it was created before the ombudsman came online. So certainly encourage people to go to the ombudsman first. That's it. And I'll stop sharing now.
And thank you, Professor Rice, for sharing that. We'll definitely look into more of the case management procedures and structures and requirements, and hopefully have some helpful follow-up. I saw another question. Are there any performance quality measures for the PHPs that might be relevant or of interest to our community? How can we find out how the PHPs are being evaluated? So there are a lot of network adequacy requirements in place. The state is supposed to be doing a lot of network adequacy checks and a lot of readiness review tests. I have to say I've not seen a lot of public information on what these readiness reviews are revealing or what the network adequacy requirements are showing. We've basically just been trying to check in on the provider networks and just hearing from clients and beneficiaries about difficulties accessing their providers. So we'd love to hear from you if that is something that you're experiencing. But there are at least requirements in place for those. But Elizabeth, feel free to add anything else.
Yeah, I would agree with that. I also would really encourage, so each of these plans has to create a member advisory committee, which will sort of be aware of problems and be a mechanism for bringing problems to a plan. They will also be able to take information from a plan back out to a community or to their communities. And it's also supposed to be a feedback mechanism for the state as well. So I would encourage people to look into being a member of a plan's member advisory committee. As we said earlier, they have to have one, like a general member advisory committee, and as well as one for long-term services and supports. So being a member of that advisory committee is really going to be important, both to hold the plans accountable and as a way to get information out. I don't think, as Becca said, I don't remember seeing anything specific to sort of HIV/AIDS or sort of other community issues in any of the evaluations. They're really, the evaluations for managed care are not as specific as you may like them to be. So we at NHELP have developed some resources and papers on evaluating managed care plans, but it often lacks the level of specificity you may want, especially because there's not a lot of sort of specific data collection and segregation of data. But I can provide some resources on managed care sort of oversight. And the other thing I want to flag is that managed care plans often have to do what's called performance improvement plans. which they won't really have any right now, but sort of in the future, as we move forward, they'll have to have performance improvement plans. And I have seen ones that are sort of more specific to certain communities or certain health issues. And it's usually a way for our plan to target improvement of health in certain areas. So I think that just thinking about that in the future, trying to push for performance improvement plans specific to you all's interests is a possibility as well.
So I know we are getting close to the 11 o'clock hour. Elizabeth and Becca, thank y'all so much. I know this was chock full of information, and I know folks probably, folks who are particularly in the weeds on this and doing some of the direct service work, or our Medicaid recipient yourself, there is a lot of information to consume, and we want to do our part to make sure the network and our community has the info they need. We will be sharing the PowerPoint slides later this afternoon and the YouTube recording if folks want to go back and watch any portion of this or share it with colleagues. We can also, as I said, certainly follow up on any additional questions folks have. The other invitation I would give to folks is that, I think we at North Carolina AIDS Action Network do really want to take these next 3 and 4 weeks to make sure, particularly our Medicaid recipients living with HIV, living with hepatitis, or are connected to our community, have the info they need about this transition on July 1, have the information to know if they're on the right plan or need to look at a transition. And so we are certainly open and would welcome doing deeper dives into any specific topics on webinars. I think we're going to be looking to do some specific writing and lifting up this transition in some of the LGBTQ spaces in the state, and would really welcome your suggestions and ideas on how we can best do that as a community, how we can ensure that everybody has the info they need. So feel free to, I think we're short on time now, but if you want to shoot me an email at lee@ncan.org, or Christina Adeleke, who's Christina@ncan.org. Both of us would welcome your thoughts and insight, or potential other partnerships, ways we can get this information out. Becca and Elizabeth, in the final minute or so, any final thoughts, suggestions, comments from either of you?
No, we'll just try to find some of these answers to these questions and any other additional information we find that might be sort of relevant and along the same lines. And are happy to sort of, as Lee indicated, like if there's further questions, please send them to him and we'll try to identify answers. Or if there's a desire for some sort of more informal question and answer session or discussion about managed care and answers, we can, pull more people in or the other things and hold that as well. So just let Lee know what you need to offer him up.
Absolutely. And I would just reiterate that while I know this was a ton of information and it's a very overwhelming change, but there are a lot of beneficiary protections involved, including to change plans for 90 days and get out of network provider and services for a while after it goes live. So there are resources to help, and we're also here to answer questions as they come up.
Thank you.
Cool. Well, thank you all so much, everybody. Thank you for spending an hour and this time with us, and be in touch if we can provide any additional information and continue this conversation. Thanks so much, everybody. Have a great rest of your week.
Thank you.
Thank you, everyone.